All right, so I'm going to briefly go through some of the physiology of articulation. I'm not going to dwell on it because, as speech therapy students, you guys are going to spend so much time discussing articulation in much more specialized classes. So, starting with the lips, obviously, the lips are responsible for the production of your bilabial and your labiodental phonemes. One thing I want you to think about and pay attention to when you're watching people speak is that, for the most part, the lower lip has the greatest range of motion and is doing most of the work in articulating at the level of the lips. And in part, this is because the lower lip is attached to the mandible. So when you're speaking, the lower lip is moving itself, but also the mandible is moving up and down, therefore helping to move the lower lip and the tongue in the oral cavity. So as you're articulating, the lower lip is really carrying most of the workload of articulation at the lips. And there are some diseases that begin with a loss of motor function, one of those being Parkinson's. And Parkinson's starts with small movements being taken out. And one of the structures of your body that has small movements is the upper lip. So oftentimes you will look at Parkinson's patients and the movement of the upper lip is gone entirely, whereas the bottom lip is still doing a great deal of work. All right, so take what I just said, and I want you to pay attention to this video of Michael J. Fox from a few years ago. He has Parkinson's disease. I want you to pay attention to the bottom lip and the top lip.
As you might know, I care deeply about stem cell research. In Missouri, you can elect Claire McCaskill, who shares my hope for cures. Unfortunately, Senator Jim Talent opposes expanding stem cell research. Senator Talent even wanted to criminalize the science that gives us a chance for hope. They say all politics is local, but it's not always the case.
So what you notice there is that the top lip really is not moving much at all. The bottom lip is maybe moving even more than usual to compensate for the lack of movement of the top lip, but the top lip's not moving, and yet his articulation is still within the realm of normal. All right, here's the next video we're going to show. This is a guy who has what's called Mobius syndrome, and then is a congenital defect of the facial nerve. So essentially he has no facial nerve, and that facial nerve is the nerve that tells the muscles of the face how to move. So what you're going to see is that, and the guy's name is Paul. Paul has no movement of either lip. So I want you to pay attention to his articulation.
Hello, my name is Paul Thornton, and I have Mealy syndrome. Now, as you can see, it affects my facial muscles, such as my lips, because I can't move my lips when I talk, and my eyes as well. So when I blink, I don't blink properly. Yeah, and also it affects my fingers as well. I've got a scar there from when I had my wedding removed.
All right, so this is an interesting video. As you can see, watching his face, his lips are not moving at all. And yet, probably when you were listening to him, you probably didn't detect a lot of articulation problems. So let me kick this back out to you and say, if you think about the phonemes that this guy, when he was talking and you were listening to him, he doesn't have any bilabials. So no P, no B, no M. There's no labiodentals. So there's no F, there's no V. He is missing entire classes of phonemes. And probably when you were listening, it sounded pretty good to you. You probably weren't latching on to all his articulation difficulties. And the reason for this is because your brain knows what phoneme, because he's speaking in a language that you're familiar with and using words that you're familiar with. Your brain knows what phoneme is supposed to be there. And he is producing the closest thing that his body can produce to those missing phonemes. And it's close enough to the missing phonemes that your brain decides beneath your level of awareness, that's close enough to a B for me to understand it and perceive it as a B. So even though he has no B, he has no P or M or F or V, he has created phonemes that are close enough to those phonemes, those missing phonemes, to trick your ear, actually to trick your brain into thinking they're there. The word for this is categorical perception. And this is a time-saving measure that your brain goes through. Your brain makes the decision, that phoneme is close enough to this, we know what's supposed to be there, so we're not going to worry about informing consciousness about these phonemes that aren't exactly right, because they're close enough to what your brain thinks should be there. Okay, and as I was already saying about the mandible is an important part of articulation because your tongue is held by the mandible, as is your lower lip. So your articulation at the level of your tongue and your articulation at the level of the lips is in part assisted by the movement of the mandible. You move your mandible for the purposes of labial articulation and lingual articulation. And you can feel this if you try to immobilize, so try to talk while not moving your mandible. It's very difficult. And especially if your mandible is paralyzed open, like this, which happens sometimes, then if the mandible is paralyzed and it's in a depressed state, meaning that it's held open, your bottom lip can't approximate the top lip for articulation, and the tongue can't approximate anything else in your mouth for the articulation of consonants or really for vowels. All right, also, I'd like to point out about the tongue. This is the most important of your articulators. If you pay attention to what your tongue is doing during articulation, it is doing a lot. It is doing a lot of dancing around in your mouth. So it's important for your lingual alveolar phonemes, your palatal consonants, your alveolar and your velars. And also keep in mind that for the articulation of those lingual alveolar consonants, that is your superior longitudinal muscle, bringing the tip of your tongue up to the alveolar ridge. For the production of the L phoneme, L, that is in part the genioglossus, which is pulling the tongue down, while the superior longitudinal muscle works to raise the tip of the tongue for the L phoneme. And the actions of lingual protrusion and retraction are not really important for articulation, but they do come into play for swallowing. When you swallow, your tongue retracts. So during the pharyngeal stage of the swallow, the back of the tongue comes back to meet the posterior pharyngeal wall during that pharyngeal constriction during a swallow. So the anterior fibers of the genioglossus are in part responsible for pulling the tongue in and back in the oral cavity for lingual retraction. And also thinking about the role of the velum in articulation, let me reiterate, the velum is raised, and remember that is the levator veli palatini, that is the primary elevator of the velum. So the levator veli palatini raises the velum to seal off the velopharyngeal port to reduce nasality during articulation, and that's done for non-nasal phonemes. And the velum is depressed, opening the velopharyngeal port for the production of nasal phonemes. And recall that the palatopharyngeus and the palatoglossus are two muscles that can work to pull down on the velum, opening the velopharyngeal port. All right, let me say a few words about the development of articulation in infants. So an infant's ability to move begins with reflexive movements. And some examples are the rooting reflex, the palmar reflex. The rooting reflex is if you take an infant and you touch their face, they're going to turn their face towards that stimulus. And it's that reflex that helps them turn towards either the nipple on the bottle or the mother's breast. So, and they're not feeling something on their face and thinking, oh, that's where the bottle is, I'm going to turn my head. This stimulus to their face reflexively beneath the level of their awareness causes them to turn towards the stimulus. And then there is called the sucking reflex that causes them to latch onto that bottle and start sucking and pulling milk out of it. So these are movements that occur automatically beneath their level of awareness. Another example is the palmar reflex. And if and when you guys have babies, that baby comes out and the doctor is going to hand the baby to the nurse, and the nurse is going to take that baby and put it on a tray. And that nurse is going to wipe that baby off, clear out, make sure their airway is clear. And then that nurse is going to take their pinkies, and that baby's lying there screaming like this, and the nurse is going to put her pinkies on the palm of the infant. And if that is and unless there is something motorically, neurologically wrong with the infant, those infant's hands will grasp on to the nurse's pinkies. And the nurse will literally lift the infant up off the table and put the infant back down. And that is a test of that baby's reflexes, which is a test of the baby's neurological system. All right, so there you see an example of the rooting reflex. So movement begins first with reflexive actions on the part of the infant. And then they slowly begin to develop their gross motor skills. And this is moving their arms volitionally, learning to crawl. The development of gross motor skills begins before the development of fine motor skills. So once that baby starts crawling, that tends to be the initiation of fine motor skills. And in this case, we're talking about articulation. So the onset of the baby's gross motor movements tends to cue the onset of the baby's fine motor movements, which in this case, we're talking about speech. So we're talking about the onset of babbling. And what babbling is that baby lying in their crib, usually by themselves or back and forth with mom or dad, saying things like ba ba ba, da da da, pa, 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 pa. And it's usually a consonant vowel combination. But babbling is what that baby is doing. That is the work they're doing to learn how to move their mouth to articulate different phonemes. And babbling leads to automaticity of speech. And when I say automaticity of speech, I mean how as adults, when we're speaking, we don't have to troubleshoot how to produce each individual phoneme. So if I was to say the word ball, I don't have to think about, okay, here comes that B sound. I got to keep my lips together. I got to start my expiratory airflow and adduct my vocal folds. And then I have to build up pressure and release that. And then I have to worry about the other vowel and where my tongue is. I don't worry about those things, but I did when I was an infant lying in the crib babbling. I just did it so much as an infant that now I don't have to think about it. My brain has motor memories stored for the production of those phonemes. So instead of having to troubleshoot every phoneme or every word or sentence that I'm saying, my brain pulls motor plans for those actions out of the memory and initiates them. And that is how, as adults, we have automaticity of speech. And that can be lost. You can have a stroke that can give you apraxia of speech. And apraxia of speech is the lost automaticity. You lose access to those motor plans that you built up when you were an infant in your crib babbling.
Oh. Oh. Boo. 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 Talk to Daddy. Boo. Boo.
All right, so you can see this infant really troubleshooting how to do boo. And it comes out like, right? She's looking at him. She's trying.